everyone, my name is Julia, I'm from Brazil and I'm currently a student of PPCR 2020 Principles and Practice of Clinical Research. And my purpose with these videos is to do a small and quick review of our topic, Module 1 of our course book, Clinical Thinking and Clinical Research. So guys, just pay attention, I'm a student, I'm not a TA, so clinical thinking while watching these videos, okay? Let's start! So guys, welcome to my second video, which is about study population. So what is a study population? This study population is the population that we are going to study in clinical trials, the population that we need to draw from the general population. But how do we do that? Well, so we have four kinds of population. The general population, which is everybody basically. The target population. What is the target population? Every individual that has the characteristic, the baseline covariate that we are planning to study, right? So everyone. Then we have the accessible population. What is it? Is the population from the target population that is accessible, so that we can reach this population. So
I live in Brazil and I am going to study Alzheimer's disease. It's not feasible for me to study population that lives in US, for example, right? So population that lives in Brazil for me is an accessible population, right? But I live in the south part of Brazil, so the population that lives in the north part is also kind of unfeasible for me. So I need to draw a smaller population for my study to be feasible so I can fund it, right?
So I need a smaller population, which I will call study population, which are the individuals that I can reach, the individuals that has this baseline covariate that I'm going to study, that I am interested in, and the individuals that fit all inclusion and exclusion criteria, right? Okay, but how can I define first the target population? I need to specifically detail this first population in order for me to get this study population right, so I have robust data at the end of my clinical trial, right? How do we do that? We have basically three topics we need to follow. First, we gotta pay attention to our study phase. Remember, we have phase 1, 2, and 3, 2, 3, and 4. And the treatment response and validity. So let's go one by one. Study population versus study phase, right? So what do we need to think of? First, the details of each phase of clinical trials, right? So phase number 1. Remember we use healthy individuals in this phase. So healthy individuals does not belong to my target population. I want disease population. So phase 1 trials, I barely need to worry about target population, much less study population, right guys? Because obviously individuals are healthy. Phase 2, so I need a more homogeneous population in order for me to have
internal validity. I'm going to explain it in further details further in this video.
So I need to have homogeneous population so I can ensure that the results of my study are true for that kind of population. So I need a more restricted inclusion and exclusion criteria. So I have to pay attention to the target population, so the target population respect these criteria, right? Phase 3 actually, I need to have a more heterogeneous population. So I can generalize the results that I got to the general or maybe target population, right? Actually target population ones, they have the baseline covariate I am interested in, right? And phase 4, guys, it is already an observational study, so I don't get to choose the population, so the drug is already being sold, right? So phase 4 and phase 1, I don't get to worry about target population, much less study population. So we have only to focus on these two phases, right? A more restricted inclusion and exclusion criteria and a more loose inclusion and exclusion criteria, right? Well, second topic, population versus treatment response. Guys, there's a difference between individuals' variability, meaning baseline covariates that differ among individuals among the study population, and variability in response. So I need to really know in my study which covariates alter my response, my treatment response, and which covariates don't. So then I can statistically analyze that in order to have true results and avoid type 1 and 2 errors, right? I'll explain that later for you also. So we need to know exactly these covariants. If there is a covariant that I don't know if alter or not the treatment response, then I have to exclude this the patients that have this covariant from the target or accessible and study population, right? These individuals cannot be part of the study, okay? Third and last, guys, but not least, validity. So what is validity? We have two types of validity, internal validity and external validity. Well, internal validity, the study is the accuracy that the study has on ensuring that the results are true for this kind of population, the population that were included in my clinical trial, right? So I can say that the results that I draw from the study is true. Well, what is external validity? So external validity is the capacity of the study results to be generalized to the general or meaning target population, right? So I can generalize the results from the population that have the same baseline covariance of the study population but were not included in my study, okay? But it is not that simple. Do you realize that for me, in order for me to have internal validity, I have to have a more homogeneous population. But for me to have an external validity, I need to have a more heterogeneous population. We have an imbalance here. How do I ensure internal validity and external validity at the same time? Well, that is why we have two phases, but because we can't, right? So first we gotta prioritize homogeneous population for us to ensure that the results are true for that population. Then we can go to a phase 3 trial so we can generalize the results for different kinds of population, meaning population that have different covariates from this population, the population that was studied in phase 2 trials, okay? Well, so I need to have internal validity to have external validity. So I cannot prioritize external validity among internal validity. That is why first we have phase 2 trials, then phase 3. First we prioritize internal validity, then external validity. Do not skip steps, guys. So, what are the threats for internal validity? Well, we have many. Confounding factors. Confounding factors are these characteristics that can alter or not the response of each individual to treatment, to this new drug I'm testing, okay? So if I don't know how these confounding factors behave in the presence of this new drug, well, how can I say that this covariance is important or act like differently? It can work as an antagonist or a synergist in the mechanism of action of this new drug, right? So we cannot say so that is a threat to our internal validity. Bias, guys. We have mainly two types of biases that can be correlated to internal validity. First, we have sample bias. Sample bias is a study population that does not represent the target population. So I would have something like that. So, for example, I have part of a study population that does represent, that have the same covariance baseline of the target population I am interested in, but most of it don't. So for example, they can have different covariates, or maybe have different degrees of the disease, or severity degrees, right? So they are different from what I am interested in, and they can alter results, obviously. And selection bias is difference between groups within the study, right? So I cannot compare the groups because they have different characteristics. So in this case, what is a threat to internal validity is the selection bias. I cannot compare two groups, and so I cannot ensure that the result that I draw from this study is true because I compared two different measures, let's say so, okay? How can I compare, for example, kilometers per hour and miles per hour? Same thing, okay? Well, maturation. What is maturation? For example, when the population in the beginning of the study may differ from the population of the end of the study because of dropouts, for example. So I cannot, same thing, I cannot compare the results that I draw in the beginning of the study with the end, right? And instrumentation. If my instrumentation is wrong, for example, or is not adequate for what I'm trying to measure, then I'll have inadequate measures, okay? So that will definitely alter the results of my study. So I won't be able to ensure that the results are true for my study population, okay? Well, external validity, threats, again. Remember that I told you about sample bias, that my study population does not represent the target population. Well, if that does not represent the target population, how can I generalize it? Okay, so there's no way to generalize. So I reduce my external validity. Okay. Well, internal validity, as I said, is a prerequisite for my external validity. I need to have results that are true for that population, so I have foundation to compare the results I got before with the results of the new drug applied to a different population. Okay, and as I said, study population need to be representative of target population. I need representativeness in order to be able to generalize my study results. Okay, so let's go to our second part of the class, which we are going to talk about different types of sampling. Remember, sampling is the technique that we use to choose our study population among all the target, or better, accessible population. Remember, sampling is directly related to external validity, meaning the generalizability of my study results. Okay? So guys, we have two large groups of sampling: the probability sampling techniques and the non-probability sampling techniques. What are they? So, in probability sampling technique, as the name already defined, is all individuals of my accessible population have the same chance, have the same probability of be chosen to be part of my study population. Okay, so they all have equal chances, let's say so. And non-probability is, naturally, we know that all individuals of my accessible population have different chances of being drawn for the study population. Okay, so what are the subtypes of probability sampling techniques? Well, First, we have simple random. So we have all the accessible population, let's say so 100 individuals, and I need to choose 50 individuals. How do I do that? Well, I need to have a complete list of all the 100 names of these people, and then I'll simply use, for example, a computerized system to randomly choose these subjects, right? Advantages of simply random. It is easy, it can be done manually, although it's much more easier to use a computerized system, and it is kind of cheap. But disadvantages. It does not defer baseline covariance that may be important for the study. It is time consuming, and sometimes you don't have a complete list with all the names of your accessible population. Systematic sampling. Well, so let's say so I have an accessible population of 100 individuals again, and I need to but the 10 individuals are from a state, the next 10 are from another, and so on. And I want to have at least 2 individuals of each state, right? So I will pick an interval, and then after each interval, for example 5, I'll pick an individual. So I'll have individuals from all of my list, okay? I will not concentrate, let's say so, which is a chance that we have in simple random, okay? So here we have intervals. They need to correlate with the sample size that I want, right? Well, and stratified sampling, what is it? So I first divide my accessible population into strata. So let's say there are some baseline covariates in each individual that are important for this study. So I want to emphasize that, and I want to have individuals with these different kinds of baseline covariates. So first I divide them into strata, and then in each strata I can apply, for example, simple random technique, simple random sampling, or systematic sampling. Okay, so first I have to divide the population into strata, then I'll ensure that I'll have all kinds of population into my study population. Okay, and finally cluster or multistage sampling. So my unit here is the cluster. So I have different kinds of cluster, for example schools in the city, and I'll pick some of the clusters, and it is called a multistage because first I have to choose the cluster. I don't have the population, I choose the cluster, and then I'll go for the population. For example, I don't have to choose all the population within a cluster. I can choose just part of it, and then I can apply these prior sampling techniques. Okay, well, then we have non-probability sampling techniques. What is it? So as I said, individuals here have different chances of being chosen for the study population. And the first example we have here is convenience sample. As the name already clarifies it for us, people are the study population are formed by individuals that want or can join the study, the clinical trial. So sometimes it is difficult to access the accessible population, or sometimes the disease is rare, so I don't get the chance to choose my population. So everyone that accepts to be part of a clinical trial will be, okay?
And sorry guys, I'm saying okay too much, I'll try to stop.
Then we have consecutive sampling. Well, consecutive sampling, it is kind of, there is no consensus among articles that I've read. So some say that consecutive and convenience samplings are different, But there are some that say that consecutive sampling is a part, and it is the most common convenient sampling technique. Well, why? Convenient sampling, individuals agree to participate on this study. Consecutive sampling, all individuals that fit my inclusion and exclusion criteria will, and obviously agree with the informed consent, will be part of the study. And finally, snowball. Snowball sampling. It is the most used sampling technique when we are talking about when it's difficult to access the patients or subjects, when it's difficult to identify the disease, or for example when the community is too close. Okay, so then we have, for example, one subject, and then we ask this subject to bring to researchers someone that may fit the inclusion and exclusion criteria. So then this individual will bring another, that will bring another, then will bring another, then we have like a snowball effect. Okay? Oh, sorry.